pulling that up. Is there a case or topic that you have been looking at that is of any particular interest to you that we should take a look at here?
No, I do have some complications at the back of my list that I haven't gone over yet, but overall anything, these are residency cases, so anything
Sure.
that you find interesting.
Right. Sure. Let's see here. Let's see. Did you want to talk about one of the complications? We can certainly do that since you've got a couple, or I'll pick something at random, but any particular preference?
No preference. Please pick something at random.
Okay, let's see. We should probably do then case number 14, which is the one where we have, it looks like the bowel perforation. So can you tell us, was this actually identified at the time of the hysterectomy or afterwards?
It was identified afterwards. She presented back on postoperative day 3 with some increased nausea, vomiting, as well as some abdominal distension. She was discharged the day prior. So she was discharged on day 2 and came back the following day with some increased symptoms that made us concerned for some postoperative concern, whether it was an ileus or a perforation or something else.
Yeah, let's start there. So this was day after hospital discharge. Then would this have been day 2 or day 3 after the procedure?
This was day 3 after the procedure.
Day 3, good. So nausea, vomiting, abdominal distension, day number 3 after a TAH with a BSO, which did involve a mucinous cystadenoma of the ovary as well. What would be your differential diagnosis here, just for those symptoms and on post-op day number 3?
So my differential consisted of just intolerance to either pain medication, inability of tolerating her diet just from slow moving bowels, just overall discomfort and pain, like postoperative pain. And then the more complicated or more concerning differentials that came about were like an ileus or an obstruction, like a bowel obstruction, and then subsequently a bowel perforation. But that wasn't really on the differential at the time. It was more of an ileus versus a obstruction.
Good. Anything else you should put on the differential? Because we usually want maybe 4 or 5 things or so. I think we're getting there.
I can't think of anything else in regards to intolerant or what I mentioned.
That's okay. Well, day 3 of wind, water, wound, walk, we're sort of thinking wind, water, sort of right in there as well. Is there anything sort of as far as early inflammation or infection that we should think of here? Wind, water, wound.
So if she presented, if there was concern for like a pneumonia picture infection or urinary tract infection, if there was like a wound infection from her fan and steel incision, or like I mentioned, medications, drugs that she might be on.
No, I think we're getting there. If she had a pyelonephritis, nausea, vomiting, abdominal distension, diaphragmatic irritation from a pneumonia, if there's also a coexisting ileus, could cause those symptoms. Well, good. So what signs then would you look for an exam that would suggest to you that there maybe was an intraoperative injury?
If there was an intraoperative...
What would you look for that would suggest more that this is something unidentified from the time of operation rather than something that was going on that actually did develop postoperatively?
By performing a physical exam on the patient when she presented to the emergency room, I would do a detailed abdominal exam just to evaluate for this distension, pain, rebound, guarding, as well as if she's having any like listening to bowel sounds, as well as if she has any presence of, like I mentioned, emesis, if it's like villus or
Okay. So if you were concerned about a a abdominal injury during the procedure, where in the bowel would you expect, based on your procedure, what are the likelihoods for a bowel injury or perforation?
So this procedure specifically was a abdominal hysterectomy. So one of my concerns would be in the small bowel closest to our operative field, potentially
Mhm.
where the retractors would be lying. If there was
Yeah.
any pressure from the retractors, or like
Mhm.
in our surgical field behind the uterus, in the action of removing the uterus. But my concerns would be in the region of the small bowel.
Hmm. Okay. It looks like a large mucinous cystadenoma of the left ovary. Is that right? Would that raise any other concerns for you?
Yes, the fact that it was a large left ovarian cyst that we removed, we could also be concerned about descending colon or the sigmoid.
Good. Great. So if you were concerned about an interrupted bowel injury that had not yet been identified, how would you attempt to diagnose that?
If I was concerned, of course, I would call on my general surgery team to come and assist me if they are available. I would evaluate the bowel by running the bowel from the ligament
No,
of tri.
we're not there yet. I'm asking you, if you were concerned, what study would you do when she came back into the ER? How would you diagnose it?
Oh, I'm sorry. I thought you meant
It's
intraoperatively.
okay.
I could do like an abdominal X-ray
Hmm.
or a CT scan.
Well, how would you choose which one to do?
Um, the flat plate X-ray would show if there were any air fluid levels in which region of the bowel, if it's throughout or the lower colon,
Hmm.
if I remember correctly.
Okay.
But which one I would choose from, I would probably, well, I could do a CT scan would also be diagnostic as well to see if it could help identify if there's any extravasation of contrast to help identify the location of the perforation, if that's what
So
you're asking.
what would you particularly order for the CAT scan? You order a CT
I would
scan of abdomen and pelvis, right? And with
abdomen
what
and
else?
pelvis with oral contrast.
With all contacts. Good. That will identify the site of the perforation for you. Very good. Good.
Yes.
So in the operating room, then if you now identified in the CT a apparent bowel injury, was this actually a small bowel?
It was.
Good. Okay. Then briefly in the OR with general surgery, how does one evaluate and manage that? Just kind of the capsule summary. What would be your steps?
So my first step would be running the bowel from the ligament of Treitz to the ileocecal valve, identifying the location of where the perforation is. Once that's identified, I would first see what kind of injury, if it was
Mhm.
a laceration versus a thermal injury burn, or if it
Oh.
was something that could be repaired.
Mhm.
If it was in this particular situation, it appeared to be a small perforation that did have to be repaired. And that was done so in 2 layers.
Mhm.
First the mucosal layer was closed with, well, I
Yep.
believe
No, you're all right.
3O.
Go ahead.
So the goal, I can't recall just exactly the suture that was used, but I do understand that in order to repair the bowel correctly without with avoiding any strictures or constriction of the bowel, you want to suture it along the perpendicular to the long axis. And so this was
Mhm.
done
Great.
in the 2 layers with not absorbable suture on this mucosal layer, followed by a silk on the mucosal layer.
Good.
Sorry, I think
Good.
yeah.
And very briefly, what would you be looking for in your inspection of this area of the bowel that might indicate you and the surgeon that a bowel resection would be required rather than a simple suture repair be sufficient? I think we better talked about this in a recent webinar also.
It depending on the depth and the length of the injury,
Oh,
and
tell me
if
about
it's
that.
near the
Specifically, what would you be looking for there?
I remember talking about this, but now it's
That's okay.
escaping me.
That's okay. Well, just very good. You said the depth of the injury. Tell me about that. If it's a perforation, I'm assuming it's from the serosa into the lumen.
Correct. And if
That all
the
perforations would be like that.
yes.
What else do you think?
Well, I'm aware that resections are necessary if the large bowel is involved, but if the small bowel is involved, a resection is required if it's going through the lumen, and there is I can't think of it. It's yeah.
Yeah. Well, you can just use any words you can to describe it. We'll see if we can keep going. So we can actually oversew or close a small perforation of either small or large bowel, but there for the small bowel, there are particular signs for which we would have to say we can't just repair this, we actually have to remove that segment of bowel because it is in some way compromised.
If there is it's like a thermal injury, or if there is signs of necrosis or loss of integrity of the tissue.
Great, good. If it were a through and through perforation, would that make any difference to you?
I believe a through and through would also need to be resected because
could
well, I
maybe
feel like you could
depending on the size. Is there anything particular about the size of it? And then we'll wrap up.
About larger than 1 centimeter in width.
Okay. Are you telling me or are you guessing?
I'm guessing.
Okay.
I don't know.
No, if you basically you pass the exam because you said if there's anything compromise the integrity of the bowel, like you said necrosis or it looked like it was compromised, then that's actually a necrotic tissue. Any evidence that a thermal injury, I think probably would, because the extent of the thermal spread wouldn't be clear, and I don't think you could actually resect and replace part of the lumen of bowel. You actually have to take that out there. But if a through and through might be very clean, it might be repairable, or if it's really sort of ragged or tissue damage, you might want to resect it. If there's any damage to the mesentery, the blood supply, if there's a hematoma in the mesentery, like that, anything that compromises the blood supply to the bowel, or if the bowel looks dusky in either way, you could. I think any of those things would be fine to say. But you did get your point across. If there's something for which the bowel is not healthy or it looks like it's been compromised, that's actually the answer. And the examiner should sort of try to get you to give some examples of it, and those are some examples. But that's basically all you need to know, because the general surgeon will be managed in the case at that point. But they're just interested in sort of what the signs are. If the bowel in any way looks unhealthy, like it can't survive if it's simply primarily repaired, then you do a simple resection.
Okay.
Good work. Thank you, Melody. That was, we got a lot done in a short period of time there. So anything you'd like to talk about or ask about this case before we go on?
For the imaging study, you had specifically asked of like how to identify the location or know if there was a bowel perforation. I guess, I've practiced this case, and obviously different questions come up every time. And that was the first time I've heard of that specifically. So is it a CT scan that you want, like what I said, the contrast extravasation? Because I feel like an X-ray you could do if you just wanted to diagnose like obstruction versus ileus, right? Was I kind of twisted on my thought process?
Well, you could usually a flat plate abdominal X-ray would give you probably evidence of obstruction versus partial small bowel obstruction versus ileus or so. Free air at day number 3, there might be a little bit of free air. If you also have significant free air, that would indicate possibly a perforation as well. But they would be very nonspecific. If you want to find out if there's a perforation in the bowel, you have to do oral contrast and see if there's a site of extravasation. So your definitive study would be a CT with IV and oral contrast actually as well. The flat plate would just give you that would be an initial survey. So if they ask you, you should say do that just to sort of to figure out whether there's concern for perforation or not. But you'd have to do a definitive study if you could with CT with oral contrast.
Okay.
Great, Melody. Thank you. That was a good case and nicely done. Thank you for going through that with us. It was helpful. Let's move right on. I think Dr. Wang was waiting. June, if you want to unmute yourself, I'm just going to zip down and grab your case list for a minute. You have it here.
Hi there.
Hey, hang on just a second. Just have to grab your case list, and I'll be with you in just a moment. Here. Ooh, hang on just a second here. We lost our case list. Hang on just a second. Just a second. That's right. Bear with us while we get this back up. There we go. All right. Here. There you go. All right. So thank you for waiting. We're ready to go. Anything particularly you would like to look at, OBGYN or office practice?
I think I'd prefer to do the OB case list and then just
Sure.
any random case
Sure.
that you find interesting. would
Okay,
be
sure.
great.
We'll grab OB and we'll get something right over here. Thanks. Let's see. Let's see. Just look through here. Let's see. Go back up here for just a second. Just to pick something at random, we picked up case number 23 right here. This is a 35-year-old gravid, 3-pair-1, history of HSV on suppression, AMA, low-risk aneuploidy screening, and she had a recognized healthy vaginal delivery. So in your practice, how do you screen at your initial obstetrical visit for whether patients might have had a history of HSV for which there might be implications for the pregnancy?
Sure. So at the initial OB visit, I typically will take a detailed history for the patient. I'll ask her about any medical conditions that are active, any medications she's taking. And then usually in the course of that, we will talk about any history of infections, including genital infections. I would say that typically is when that topic would come up. And if it does, then I would want to know more details about the types of outbreak and the frequency and whether she's on any medication.
Ah, good. Okay. So if you have a questionnaire and it asks for a history of infections and the patient discloses to you that she actually has been told that she has herpes virus infection, and it was actually because she had STD testing with her primary doctor and she tested positive for both HSV1 and 2. How would you begin to work up and determine whether this is an issue that would be of concern for the pregnancy?
For this patient, I would want to know essentially what prompted the testing. So was it because she had lesions that were suspicious for herpes? Was it just part of a routine panel?
If it were just part of a routine panel screening, she said, "Oh, be tested for all STDs," and her primary doctor just did it.
All right, that sounds about right.
Yep.
In that case, I would ask the patient specifically if she has had any lesions to her knowledge in the past, whether she's noticed any like bumps or ulcerations or anything in the vaginal or vulvar area. So yeah, that would be, I think, my main question.
Good. No, that's it. The examiners are just waiting for you to say the word genital, and if it weren't, they would ask you then. If she said she had lesions, what follow-up question would you get? If she disclosed that she had a documented history of oral HSV aphthous ulcers, are there implications for the pregnancy here that we should discuss?
So typically for oral involvement, we're talking more about HSV1.
Okay.
In these patients, I would tell them that assuming that they never have genital lesions, the risk to the pregnancy is very low. However, I would counsel them that if they have any prodromal symptoms or notice any lesions, they should notify my office right away. So they can.
So you say if they have oral lesions, they should notify your office?
Genital lesions.
Just got it. No, good. You bring it back to genital. There should be no, if somebody has a history of HSV, they would not be actually having likely viremia that would affect the pregnancy if they had a recurrent oral HSV lesion. Genital HSV lesion would just be concerned about surface contact. So if the patient disclosed that she believes that she had genital HSV, but she's actually never had confirmatory testing for that, but she saw her doctor and they said it looks like it could be herpes. How would you manage her pregnancy based on this?
For this patient, I would counsel her that In her situation, out of an abundance of caution, I would recommend suppression for HSV beginning at 36 weeks gestational age. I would also again want her to notify me right away if she does have prodromal symptoms or any evidence of active lesions, because that could influence the route of delivery.
Good. Okay. So you said you'd recommend suppression at 36 weeks. Would there be any indications or anything that would turn up during pregnancy which you might start her on treatment prior to 36 weeks?
I think for most patients, the only situation where I would start treatment earlier is if they did have evidence of a genital outbreak. I think if the patient were symptomatic, I would not.
Right. Yeah, good. For a documented outbreak or concern for an outbreak during pregnancy, you might just start at that time and continue for the rest of the pregnancy. What medication do you use in your practice for a suppressive treatment of genital HSV for pregnant patients?
Sure. My preference would be to use Valtrex, 500 milligrams twice daily, up until the time of delivery.
Yeah. If your patient told you that she's actually, when she first was diagnosed with HSV, her primary doctor talked with her about suppressive therapy, and she was actually treated, but she was given 1,000 milligrams once a day, and she asked why she has to take the medication twice a day. How would you discuss that with her?
I would tell her that it's very important to suppress the virus and prevent viral shedding at the time of delivery due to the serious consequences of having infection of the neonate. So unfortunately, that we believe that the twice daily dosing is more effective for that purpose.
That sounds fine. They're pushing you to zero, right? Just because the CDC has studied recommended that we have more effective suppressant if in pregnancy we do 500 BID rather than 1,000 twice a day. As soon as you say that, you pass the exam, and that's perfectly okay. When this patient comes in then at labor on viral suppression and you're doing the right thing, she'd be doing 500 of valacyclovir twice a day. What particular screening would you perform if she comes in labor to labor delivery at full term to determine whether it would be safe, whether it would not be safe for her to have a vaginal delivery? What particular things would you be looking for as far as things you'd ask for on a history or things you'd look for on an exam?
Sure. So when the patient arrives, I would ask her whether she has had any, whether she's noticed any lesions in the genital area that sound suspicious for herpes. And then I would also ask her if she's had prodromal symptoms such as burning or irritation that would heighten my suspicion that she could have an outbreak. And at the time of arrival, I would do a sterile speculum exam to look for any evidence of active lesions.
Oh, okay. Where would you be looking for evidence of active lesions in this patient?
I would be looking on the external genitalia, and then I would also be looking on the vagina and on the cervix as well.
Perfect. Good. The examiners are asking open-ended questions just because they wanted to be sure when you said speculum exam, they're thinking, are we thinking that we only have to look internally? And of course, most of the lesions are external. So that's all you have to say. This is just when they ask you a question like that, just sort of specifying, just as you're doing this is perfect. If the patient reported no lesions, but she did have it sounded like there's prodromal, she said local burning and irritation for a few days. How would you determine whether it's necessary for her to have a cesarean delivery?
So for this patient, technically, if she doesn't have active lesions and she's in active labor, it would be reasonable to move forward with a vaginal delivery. Now, if the patient had, if she had a high amount of anxiety about the situation, she requested a cesarean delivery, then after appropriate counseling, that would probably also be okay.
Absolutely true. Yes. Is there anything else that you might, as far as ferreting this out further, because you said this is a potential high-risk situation for the baby. Other questions that you could ask that would help to determine whether there's really an indication for C-section here or not? given she's reporting things, prodrome can be a non-specific thing. Because you said if she had no lesion, you might actually allow for vaginal delivery if you're active labor. But if in fact she's describing a prodrome, is the baby at risk? If in fact that's what it really turns out to be.
Sure. To be honest, I am not entirely sure. However, I imagine that there would be a small amount of risk, potentially.
Well, based on what we know about gender,
go
ahead. I'm sorry, I interrupted you. Go ahead.
Oh no, on second thought, to my knowledge, neonatal heartbreaks can be extremely serious. So I think if our typical practice is to allow vaginal delivery in the absence of active lesions, I think the risk is probably very small.
Good. When we have an HSV outbreak, regardless of where in our body it is, can you tell the examiner, is there a particular period of time during which the virus travels actually down the nerve to that patch of skin, during which it is actually there and contagious or capable of being transmitted relative to the time when the lesion appears? What's the window during which the patient could be actively contagious?
I think it would just be around the time perhaps a little bit before the lesion appears, and then a couple of days as it's resolved.
Right.
But once it's crusted over,
it would not be right when the lesion appears. It would be before the lesion appears. So during the period of prodrome, the patient actually can be actively contagious. Would that change your thought on this in any way?
That's a great question. I think for this patient, if she had symptoms that were highly suggestive of prodromal HSV, and she really wanted to do the best thing to absolutely eliminate the risk, then we would have the discussion about cesarean delivery.
Okay. Are we interested in absolutely eliminating the risk, or eliminating the risk as much as we could?
Well,
I think the examiners want us to say we really want to eliminate the risk because the risks for the baby actually are serious. But you hit on this. Will be our last question. We'll wrap up here. You hit on it. You said that the symptoms highly suggestive of an HSV program. What question could you ask the patient which would help you to determine whether this is just something non-specific like a little bit of irritation or maybe vulvar candidiasis, or whether we're actually dealing with an active program here?
I guess you could ask her more questions about her history, like whether she's noticed any sort of vaginal discharge in association with her symptoms, whether her symptoms are with urination. So I think you could ask her more detailed history to try and discern how high your concern should be.
Well, if this patient has a history of genital herpes, she would have had outbreaks before, right? If she can identify for us that she has had outbreaks before, is there a particular question that you could ask her?
You could ask her how similar this feels to her prior episodes.
That's all. That's the only question we need to ask is, based on your previous experience, does this feel to you like a prodrome? And if she says feels nothing like it, no, it doesn't really seem like what I usually get, because what I get is this area here, and this is more generally around here, then we're in a bit of a quandary, but that's less likely. But if she says it does seem to be, because remember with HSV, it's localized to a very specific area. The lesions always occur at that nerve that feeds that little patch of skin, right? So if she's telling us it's in the same area, it feels like a prodrome, that would be all the examiners would need to hear. So if you could tell them, you would ask the patient, how does this compare to your previous episodes of HSV? Does it seem like you're getting outbreak? And she said, yes, it does. That's the answer. If she said, no, it really doesn't feel anything like that, then you're going to have to make a judgment call. If she says, I'm not sure, you're going to have to make a judgment call. But I think where the examiners would want to go here is if there is uncertainty here, and this is a patient who has a history of HSV, and she's given symptoms that sound not so much like a yeast infection, but maybe a prodrome, you might err on the side of caution just because of the implications for the baby.
Got it. So in that case,
I would probably go that way. But you're right. The
Okay.
question you want to ask is you simply want to learn the history. You want to know is how does this compare? Does this seem to you like it? Because the patients want to experience it. Does it seem to you in any way like it? She said, yeah, it kind of does. I'm pretty sure you would probably take her to the OR.
Right. Okay. Got it. Thank you.
Good work. All right, good. I'm glad we hit that, but that's a topic that's not talked about very often. But there's the basic things we talked about here is just sort of how do we elicit history? Because so many of our patients will come in and they've been told they have genital herpes, but it can be on the basis of serologic testing. We have no idea where it is. We do obviously want to know that it's genital rather than non-genital. That's the first question to ask. And it seems so obvious that in the exam we forget to say it. But we do have to pin that down. And then we have to talk about sort of surveillance and when to do them during pregnancy suppression, surveillance, when to start medication, what medication to use, and then how to manage the issue of a patient who comes in at labor and how we screen them. And we do want to be specific with our screening as to what the index of suspicion is. And that's basically the entire gamut of questions they could ask you about that. June, thank you. Any question you'd like to ask otherwise about that?
No, that was great. Very helpful.
Good
Thank
work.
you.
Thank you for doing that with us. We got a lot of good information out there, I think, on that one. That was nicely done. Thank you. Move over here. I think Dr. Elwin had been very patiently waiting. Dr. Elwin, coming to you in just a moment. Dr. Elwin, you had your hand raised before. I'm going to click if you'd like to unmute yourself. There you are. Can you hear us, Dr. Elwin?
Yes, thanks.
All right, thank you. Good. Thanks. Let me just get down here. You were. This is down here. All right, ready to go. OBGYN office. Any preference?
We can do GYN.
GYN, sure. Let's see, go right here. Have you been looking recently at any particular cases of interest or topics that you'd like us to pick up?
No, I'm pretty open.
Let's see. Let's get this kind of cruise all the way down and come back from the other side of the case list here. Let's see. In the past few webinars that we've done, has anybody talked about bartholin cysts? Because you've got a couple here.
Not that I've been.
Okay, could we pick one? All right. Let's pick case 36 of the 31.
Sorry.
So in your practice, when you're dealing with a patient who has a bartholin gland cyst, how do you determine whether this can be managed simply in the office or whether it does require marsupialization or an excision in the OR?
So in my practice, typically, if a patient has a bartholin gland cyst, I typically will try to expectantly manage it if it's less than 3 centimeters. But if it is very bothersome to them and it's the first time that they've had it, then I would recommend an IND with a ward catheter placement. And then if it's a recurrence, then in that setting, I typically recommend a bartholin gland marsupialization, which I perform in the operating room.
Okay, so if this would be an initial one that says recurrent, but starting out the first time this patient had one, how do you counsel them about sort of how IND and word catheter placement can assist them, and how do you counsel them about sort of just benefits versus risk associated with this?
So I counsel them
just taking her to the OR for a primary lesion.
So I counsel them that these cysts can resolve on their own. However, they can be pretty uncomfortable, and so a lot of patients have pretty significant relief from the IND, and that the word catheter is placed to allow a tract to epithelialize, so that way the gland can continue to drain.
Good. How long do you usually leave your word catheter in place?
So I would try to leave it in place for several weeks. However, in practice, it seems to fall out well before that.
Yeah, it does. Yeah. If you had your preference, how long would you like it to stay in?
I think ideally up to maybe 4 weeks or so, 4 to 6 weeks, to allow reepithelialization to occur.
That is true, but it's uncommon for them to stay that long. But how would you counsel her in your practice and in your hands? How do you counsel her about the likelihood that she might, if we do it this way, that she might have a recurrence at some point?
I counsel her that there is a high risk of recurrence with these cases, particularly if the ward catheter falls out early, which in most cases it does. And so, in that setting, then I recommend the marsupialization. Once a marsupialization has occurred, it's much less likely to have recurrence because that tract is sewn open.
Okay. So if this patient were 61 years old instead of 31 years old, and she came in reporting that she remembered years ago that she'd had a bartholin cyst and they've been incised and drained at the office. And she now reports sort of a swelling and discomfort, which is increasing in this area. And on your inspection, it looks like it is in the area where there might be a bartholin gland cyst. Would there be anything else on your differential diagnosis other than a bartholin gland cyst that could occur in that area in a menopausal woman?
I would be more concerned about a vulvar squamous cell carcinoma or a malignant lesion. And so, and particularly in a postmenopausal woman, but really I would say anybody over 45 to 50, I have a I would recommend.
Okay. Why are you picking in particular a squamous carcinoma? What's your thinking behind that?
I'm wondering now if I'm getting it confused with lichen.
No. That's just it. The examiner's job is to challenge, and our job is to defend. And it's just a very simple question. They're looking for just a simple answer. They're not saying that you're wrong, and you're not. They're just asking for you to elaborate a little more on sort of why the first thing that came to your mind was squamous carcinoma.
I believe that these can be associated with that because it's a gland. I suppose it can also be associated with adenocarcinoma, which would be more common in a gland. But
okay.
Review.
Okay, so I see what you said. So if this were actually a bartholin gland carcinoma, would it more likely be squamous or adenocarcinoma?
It would more likely be adenocarcinoma.
Got it. Good. However, going back to the question we posed originally, why was it that squamous came to your mind first? If we had a lesion at the, let's say, left inferior vulvar,
because that would be the most common lesion.
There you go. That's all the examiner was waiting for. Exactly. Squamous carcinoma is like by far the most common vulvar carcinoma. Bartholin adenocarcinoma, very, very rare. That's all you have to say. That in answer to the examiner's question, when they ask that question, don't panic or do not think, gee, if I said the wrong thing, you haven't. That's the reason why this comes up first. They would then want to probe, though, if it were in the area of a bartholin carcinoma, what would it be? And the knowledge point they're looking for is that is often a glandular adenocarcinoma. So you've answered correctly twice there. So in fact, you're doing great. If you had a suspicion that this might actually be a bartholin gland carcinoma, just because of the appearance, it looks sort of red and angry and irregular. What other findings on examination might suggest to you that this was a carcinoma rather than a cyst or abscess of the bartholin gland? No, they're just asking about sort of how would you work it out, what are the local findings or examination might you check for?
I would look to see if there's any inguinal adenopathy.
You're nailing it. That's all that works exactly. We would be less likely to see that with a Bartholin's abscess or carcinoma, and if we would, it would be sort of inflamed adenopathy. On your exam, what would be the difference between adenopathy, palpable adenopathy related inflammation, and adenopathy related to carcinoma? Is there a way that you can tell the difference by palpation?
Not that I can think of. I want to say that perhaps it would be more firm in carcinoma, but I can't say that.
Well, there would be one simple thing. If this was due to an abscess and you palpated the lymph nodes, would the patient tell you anything about sort of what she was feeling while you palpated them?
It's more likely to be tender in that setting.
There you go. That's again, these are straightforward answers. We just have to be able to verbalize them. Because if I were watching you do this exam, I'm really sure if you were wondering about this, you palpate and say, does this hurt you at all? Because if it's a malignant adenopathy, that's generally not tender, right? Mm-hmm. They'd be clustered, but they would have good. So if there's a concern for adenopathy which is non-tender, and this patient has something that looks like it's a Bartholin abscess, and you're a little concerned about it, how would you proceed with evaluating this?
So in this setting, I would, if I was concerned with malignancy, then I would actually recommend referral to my urogyn colleagues, so she could have a complete excision, so they could send the gland to pathology. I don't perform Bartholin gland excisions myself due to the bleeding that can be encountered in that setting.
But you said you send it to urogynecology?
That's who does it in my facility, is urogyn. Alternatively, I guess if I'm concerned about a cancer, then she should go to gyno.
Right. Got it. Okay. Would you, in your practice, consider biopsying this if you were concerned that it was a carcinoma, just to have a diagnosis?
That would be reasonable, yes.
Okay, right. But you said you preferred, is there a reason why you prefer to send it to urogynecology or urogyn rather than biopsy it yourself?
I think if I was going to excise the gland entirely, then I would not want to do that. Biopsying it would be.
Okay. Good. Good. And you said you were concerned about sort of managing the office due to risk of bleeding. If you wanted to, I think in a 61-year-old who had something you were concerned with, an adenocarcinoma of the bartholin gland, biopsy in the office would be associated possibly with a significant risk of bleeding, right? It would be fine if you had clinical concerns to say I'd refer to GYN oncology and have them biopsy it to find out, because I would not want to get into difficult to control bleeding in my office. They're more likely to be able to figure out whether they can do it in office OR. Does that sound like a reasonable response?
Yeah, definitely. Thank you for that.
I would come up with that. Good, great. Very briefly then, if this actually was an adenocarcinoma of the bartholin gland, you referred to GYN oncology, what procedure would they generally discuss with the patient and perform?
I believe at a minimum, they would probably do a radical vulvectomy.
Mm-hmm. Yeah, no, that's exactly right. If it's an adenocarcinoma, it would be a big, yeah. And what are the components of a radical vulvectomy? Now, remember, just for a moment, just because I'm going to move on and more. Remember, we've talked about a number of times when you get deeper and deeper and deeper into the question, we always are asking ourselves with each question: is this the point where I need to say I don't know, and you could at this point, or is this the point at which we're way out of what I do as a generalist, and in the setting of my examination, this is something that somebody else does, and I can bail based on that. So you can't actually go there. So if you have an idea of sort of what is done during a radical vulvectomy, you can answer that.
Yeah,
it's also acceptable to say, I actually have to look this up, but I'm going to push you a little bit. Just what are the basic things that we would do?
I'd have to look that up, but I believe that they would, at a minimum, remove the vulva on that side, and then consider a some sort of either sentinel lymph node biopsy or.
There you go. Exactly. It's actually removal of the malignant tissues and around it. And it actually is sort of like I believe it would be a hemivulvectomy, but you want to mention that they're also doing a lymphadenectomy. That's exactly right. So if you were to say they would do an excision of a wide excision, getting margins and getting down to the fascia at least, if not below, on the tissues on that side, and they would do lymph node sampling, that would be all the examiners would want to hear. You'd be perfectly okay. So again, just the answers that are coming to your head in each case are the correct answers. So don't be hesitant about bringing them up, because in each case you actually headed exactly where the examiners want to go. You did great. Okay. That was nicely done, and again, not something that we're likely to discuss again between now and the exam, probably.
Perfect.
Tina, anything you'd like to ask otherwise about this case before we move on?
No, that was good. Very helpful.
Thank you for doing that with us as well. Good job. All right, let's see. So according to the rules, I do need one of our candidates who is actually on the list of people who are supposed to be on the hot seat. So I'm going to pull around. I believe Dr. Batista and Dr. Brar at the top of the list. Let me see if Dr. Brar, if you would like to unmute yourself. I think you're someone that we can control on the seat. There you go. Dr. Brar, are you there?
Yeah, I'm here. How are you?
Okay, I'm happy to have you here this evening. Got your case list right up. We are ready to go. So I think your choice, OB/GYN or office?
Either GYN or office would be preferable.
Let's see. Okay, could we do office because we haven't done office yet this evening? We'll hit that real quick. While we're doing this, are you looking at anything particular on your offices that you'd like to discuss, or just is there a topic of interest to you that we should pull from in here?
Whatever you would like.
Okay, that's great. Let's see. Let's see, let me get down here for a moment. I'm going to pick you have so much stuff on your case list that is just OB, obviously. We're going to pick something that has to do with pregnancy, but I'm going to pick a fixed case number 16, because it's a 28-year-old permagravid patient, positive pregnancy test. I'm going to take the rest of it off there. If you have a patient who comes with a positive pregnancy test and it's positive and she is uncertain of her menstrual age, what's the first thing that you would do as far as working this patient up? Comes in report of a positive home urine pregnancy test, unknown menstrual period.
The first thing I would do would be a detailed history.
Sure.
I would do a physical exam, and then I would do a bedside ultrasound.
Okay, that's great. Let's see. I'm going to do down here for a moment. Let's see. Okay, could we do office? Because we haven't done office yet this evening. We'll hit that real quick. While we're doing this, are you looking at anything particular on your offices that you'd like to discuss, or just is there a topic of interest to you that we should pull from in here?
Whatever you would like.
Okay, and if your ultrasound identifies no evidence of a pregnancy in the uterus and nothing in the adnexa, where would you go from there?
So assuming that she had a completely uncertain last menstrual period, I would get a serum HCG.
Oh, okay, great. Let's see. If your serum HCG is 2800, where would you go from here?
Yeah, so at this point in time, I would likely give the patient kind of anticipatory guidance. If she wasn't already taking a prenatal vitamin, I would tell her to start taking a prenatal vitamin. I would probably hold off on doing my initial prenatal panel until I establish the viability and location of this pregnancy. But I would tell her that HCG is below the level of my discriminatory zone, and so I wouldn't have a diagnosis at this point, but I would repeat the HCG in 48 hours to establish some sort of trend.
Good. Okay. If in 48 hours it went from 2800 to 3500, what would you do at this point?
I'm sorry, say that again.
That went from 2800 to 3500 in 48 hours. Where would you go at this point?
So if in 48 hours it went from 2800 to 3500, then I would counsel her that she likely has a abnormal pregnancy. But that my differential at this point was between a failed intrauterine pregnancy versus an ectopic pregnancy. I would expect 2 days later that probably wouldn't be able to see any signs of an ectopic on ultrasound, but it might not be a bad idea to repeat the bedside ultrasound just to see if something had popped up in the last couple of days. And at that point in time, given that I have ruled out a concomitant IUP, I would offer her methotrexate if she didn't have any contraindications.
Oh, okay. So are you going to do repeat ultrasound first or methotrexate first?
So I would do a bedside ultrasound, because if she had an obvious adnexal gestational sac or cardiac activity, then
sure,
I would counsel her that this was very suggestive of an ectopic pregnancy. And if that was negative, then I would offer her methotrexate.
Sounds good. If your ultrasound identifies a small, just irregular gestational act in the cornual region of the right corneal region of the uterus, how would you manage this information? And I'm assuming this is on a bedside ultrasound.
A gestational sac in the corneal region, you said?
Yeah.
So I would, at this point in time, I would counsel her that this likely represents a corneal ectopic pregnancy, and talk to her about the increased risks that are associated with that versus a tubal ectopic. And then I would talk.
Tell me about that. What are the specific risks then that you would counsel her about corneal versus ectopic pregnancy?
So yeah, I would counsel her that a corneal ectopic does have a increased risk of rupture as well as catastrophic hemorrhage, and is less likely to be responsive just to sole methotrexate therapy versus a tubal ectopic.
Okay, so what options would you offer her then as far as managing this if you were suspicious that it's a corneal ectopic?
So if it was a corneal ectopic, I would talk to her about kind of a multimodal approach. I would offer her local methotrexate injection into the gestational sac. I don't. In my experience, my corneal ectopics, though, I have principally managed with doing a wedge resection, either laparoscopically or via laparotomy.
Okay. In your practice, would you do intralesional injection of methotrexate?
I have not personally done that for a corneal ectopic, but I.
Okay, but no, you're right. That is a potential option. Yeah. So the options, it sounds like you're saying, are intralesional injection of methotrexate, systemic methotrexate, or corneal wedge resection. How would you decide? How would you figure out whether this patient should be managed more likely by a corneal wedge dissection? And looking at sort of her presentation, are there particular things, indications for which you feel that surgery rather than medical management might be appropriate?
Yeah, so if she was having a significant degree of pain, if she was already hemodynamically unstable, I'm sorry. If she, I would talk to her about potentially the future risks in subsequent pregnancies if she had a large amount of her uterus resected, versus if she didn't desire any future childbearing. And then via a shared decision-making approach, we would arrive at the best management for her.
What in your mind would be the risk to a future pregnancy then, if you're talking about potential surgery with her?
So in patients that have a corneal resection in an index pregnancy, she would have an increased risk of having a potentially a uterine rupture or going into preterm labor in a subsequent pregnancy.
Okay. So you mentioned that outside of things like hemodynamically stable or concern that it has ruptured, you'd consider between methotrexate and surgery, if there are no immediate indication for surgery, how would you determine whether to counsel her about surgery or methotrexate management? What would you be looking for as far as indications to guide you in your decision making?
So I would start off by seeing if she had any contraindications to methotrexate.
Sure, good. And outside of that, what would you be considering?
At that point, I would have to look it up or likely consult my MFM.
Well, tell me, what are you thinking there that you're uncertain about?
I'm sorry, say that again.
What are you thinking of there that you're uncertain about? So far, I mean, I have to say for all of our candidates this evening, again, we're sort of practicing the exam scenario, and the examiners will sort of challenge with questions. Every one of our 4 candidates, Dr. Barr is our 4th, has done nice discussions right down the road. There's been no second in which there's been any question that any of our 4 candidates so far was in any danger of not passing the exam. And Dr. Barr, this is true for you so far. Everything you're saying is exactly right. You're making perfect sense. The examiners are really pressing though, because it sounded like you were thinking interlesional methotrexate might be a consideration, but you'd sort of go methotrexate more versus a corneal wedge resection. And it sounded to me like you might actually be a practitioner who leans sort of just as an option more towards surgery rather than methotrexate. So they're trying to figure out sort of if the patient is not at risk, is totally stable, how do you figure out whether to recommend medical versus surgical management? Are there particular considerations, or is there sort of a short checklist you have in your mind as far as outside of that she can't take methotrexate? And they're getting ideas to your mode of practice. Now, are you someone who usually operates, or are you someone who would do methotrexate? And if so, how do you sort of figure out for a given patient what would be the best thing to recommend?
Yeah, so aside from contraindications, I would talk to her about, the fact that if she had intralesional methotrexate, there's a chance that she could still require a wedge resection down the line anyways.
Sure.
I would, again, talk to her about potential implications in future pregnancies, which could potentially be avoided if she did have successful intragestational sac methotrexate administration.
Right.
I've talked to her about the risks of surgery itself in the pregnancy, including risks of anesthesia, risks of hemorrhage at the time of wedge resection, as well as other concomitant risks that are inherent to all abdominal surgeries, such as infection, venous thromboembolism, injury to nearby organs, etc. So after talking about that, contraindications, future considerations, I would ultimately leave it up to the patient.
There you go. I think that was nicely said. I think you're speaking very nicely and very clearly. You discussed these things in a very professional way. That was exactly right. The considerations are, if she's absolutely stable, that overall we do try to manage these things a little bit more conservatively, because a corneal wedge resection does carry greater risk to the patient in a future pregnancy, but also it's a more risky procedure than just doing a simple self-injectomy for a fallopian ectopic. That's kind of routine these days. So we do want to think about where to go with that, and you're counseling the patient appropriately. And it sounds like you have a balanced mode of practice where you might err a little bit on the side of methotrexate, despite that you said that methotrexate has a lower likelihood of success with this than with a fallopian or ovarian ectopic pregnancy, which I think is true too. And the examiners would be completely on board. And the last question they would ask you then would be, so if you decide to treat this patient with methotrexate, what are you looking for on your surveillance that would indicate to you that you had to go ahead and operate on her, despite having tried the methotrexate?
Oh,
So she had methotrexate. What's your continuing surveillance consist of, and what are the warning signs that you look at for which you're going to take her to the OR? That's what they're asking.
yeah. So, so for a non-corneal ectopic, I would generally be looking for a 15% decrease between day 4 and 7. I would have to look up whether that also applies to a corneal ectopic.
I think it's reasonable. Sure.
Um,
Sure.
yeah.
So we're looking for indications in which you would say, this is not working. We have to go to the OR. Can you give me just a short list of a few things while you're doing your surveillance for which you would change your management plan?
Yeah, so things that I would definitely take her to the operating room for during post methotrexate surveillance would be inability of the HCG to decline appropriately after
Good.
giving methotrexate. If at any point she became hemodynamically unstable,
Very good.
she had signs of an acute abdomen, or
Good.
she had a positive FAST exam, so concern for rupture, or yeah, and those are the main ones I can think of.
That's exactly the same as for a fallopian ectopic pregnancy. Otherwise, the one thing there that the examiners were interested in said if you couldn't get her HCG titers to go down, when that doesn't happen with the fallopian ectopic pregnancies or routine ectopic pregnancies, we often consider a second dose of methotrexate. For a cornual ectopic pregnancy, is that something that you would consider? If she didn't respond to her first round, would you consider a second round as opposed to taking her to the OR?
I would likely have, given like I said, the decreased chance for success in this setting, I would have a lower threshold to take her to the OR in comparison to a fallopian tube ectopic in the setting of a failed.
Good. They're just interested in sort of where you're going to go, your index of suspicion, sort of just how cautious are you about that. Another acceptable answer would be, if it looks like from your practice that you're in a community where you have pretty good resources available to you. You've got MFM and GYN oncology and people like that. Are they around close to where you are?
Correct.
Yeah. So you could say, you know what, this is a tough one for me, and because the surgery is more risky. I've not, done second round methotrexate for a corneal ectopic pregnancy. I would consult with one of my experienced colleagues, perhaps GYN oncology, or MFM, probably GYN oncology, to see what they thought, and that would guide me in that case. And that again is keeping your patient perfectly safe, because if you're not sure and someone more expert could help you to give the patient the best management, you're going to call on them. That's exactly what the examiners would want to hear. So everything that you said right down the line, perfectly fine. And you remember you get 5 or 6 questions in, always just bring in that you could ask somebody for a second opinion if you'd like to. That's never wrong in the exam.
Thank you. Good
work. Thank you for doing that. This is actually going really well this evening, I have to say. Let's get back over. Let's see. Dr. Foley has given me a list of candidates that I need to be sure I'm going to call on this evening. I think Dr. Binstead is actually one of them. Let's see. Batista is supposed to be one of them. Hang on just a second. We'll get where we need to get here. Just a second. Thanks. Dr. Brown, I think we do need to talk to Jewel. Dr. Brown, if you can unmute yourself, I will go and grab your case list here for a moment. If you'd like to participate, just go ahead and unmute yourself. I'll give you a minute. If not, we'll move on to one of our other candidates. And if you don't want to, that's okay. Oh, Dr. Yeats, do have to get to Lauren. Again, we'll go to Lauren first. Lauren, if you can unmute yourself. Your case list sitting right here.
Hey, can you hear me?
Gotcha, right here. Thanks for joining us. All right, ready to go. OBGYN or office? Or anything.
Whatever you would like me to do is fine.
Okay, let's see. Well, maybe we'll rotate back around to OB. We'll just sort of keep rotating through here. So we'll go to something OB-like. Let's see. Just a second. We'll find something simply good here. Just cruising through your entire case list here for just a moment. Actually, I'm at the top of it. So great. We're looking at case number 3, which I'm sure you are thinking as a case the examiners will never ask you about, because it is. It is a 31-year-old. There's nothing going on. She had no antenatal problems at all. She actually got to full-term pregnancy. She labored, she delivered, she had a beautiful outcome. No deal. But this, especially on page 1, they'll go to something and they will start with a very general, very simple topic to get the 30 minutes going. And if I were the examiner, I would say, so doctor, I see here, I don't notice that you have elective inductions on your case list, but you do have this patient who delivered at full term. In your practice, how do you discuss with your patients the option of elective induction of labor?
How do I discuss with my patients?
Yes, how do you review with them sort of, what might make them a candidate, or under what circumstances you consider offering elective induction of labor at term?
For elective induction, our hospital policy only allows elective inductions after 39 weeks of gestational age with and even with that, with a favorable Bishop score.
Oh, good. And what in your institution, what is a favorable Bishop score? That's the threshold for being able to do elective inductions.
Bishop score of 8.
Bishop score of 8. Good. Okay, great. So basically your criteria are 39-week gestation and favorable Bishop score, and then you would consider offering a patient an elective induction under those circumstances.
That's correct.
Good. That's fine. We're not saying you'd offer everybody, but that would be a good. So how, in your practice, how do you go about, for a patient like this, determining that you do have a reliable 39-week gestation? When you're working with her prenatal record and you decide you're going to offer elective induction, how do you assure yourself that she is at least 39 weeks of gestation?
So ideally, I would have a sure last menstrual period that was confirmed with a first trimester ultrasound.
Ah, good. Okay. So LMP and ultrasound. When you're asking a patient about menstrual period, how do you determine the issue of sort of assured or certain menstrual period? What questions do you ask her?
I ask her the first day of her last menstrual period, how long her periods generally last, on number of days, and do they seem to occur, monthly.
Got it. Good. Of that, what would you say is the most important? You said 3 things there. What's the most important thing you want to know? Is the date? You want to know whether the date is certain? Do you want to know how many days it lasts, or do you want to know how often the periods turn up?
The certainty of the first day.
Good. After that, what's the next most important thing you would want to know? How often they occur, or how many days they last?
How often they occur.
Good. Sounds good. So the examiner's just running you through it. It's just the number of days that they last. I'm not sure was that important, but you're ferreting this out very nicely. You're stratifying very well. So this is perfect. So in order to say that she has a certain menstrual period that's comfortable for you, she has to know the date, and she has to have roughly monthly menstrual periods. Yes. Good? And then you said you'd confirm that with a first trimester ultrasound. In your practice or in your community, what is the standard error of measurement on a first trimester ultrasound for dating?
We ideally try to do a first trimester ultrasound around 8 weeks of pregnancy.
Sure.
So that's about 5 days of error.
Plus or minus 5. Good. Great. If the patient turns up and does not have a certain menstrual period and turns up, let's say at 14 or 15 weeks by your clinical examination, how would you work out then, if you look back in the record, you realize that one of your partners has seen her and that's what you got? Turn up maybe 14 or 15 weeks not knowing about a menstrual period. How would you then attempt to identify an appropriate gestational age? What other things might be in the record for which a practitioner could have tried to determine a gestational age?
It could be just any recent ultrasound, whether that was first or second trimester.
Okay. Well, if she turned up at 15 weeks and had not been seen in the practice, could she have had a first trimester ultrasound?
It's possible that she could have had one at another facility.
Yes, there you go. Now the examiners they're just ferreting out. This is the really common discussion. So, right, I would always allow, well, if she was not seen until 15 weeks, we're going to talk about standard error. It's a little bit larger there. But right, is there any medical encounter you go back to where she's really in a good range where she actually maybe at that point she remembered she told somebody she had a menstrual date, or maybe she got an ultrasound and she was 7 weeks pregnant. That's perfect. Outside of that, if that's not available, what other things might we be able to do to establish a gestational age? If someone who presents maybe in the second trimester is not certain of her menstrual period.
You could talk to her about a possible estimate date of conception.
Sure, that would be great also. Sure.
Could talk to her if this, ask her if this is a pregnancy that was from assisted reproductive technology,
like
IVF or IUI.
Good. Yeah, you bet. Yes. Anything else? As far as questions you could ask her, anything else?
If it's 15 weeks is early, we can ask her if she's experienced any signs of fetal movement.
Oh, yeah. And if she actually is experiencing fetal movement this week, how does that help you?
Helps me, believe more reliably that the 15 weeks, or she's in the second trimester.
Well, that's true, but the second trimester is 13 weeks long. So how does that help you as far as determining sort of more reliably what her actual gestational age is this week?
Well, it's just, when she, if you can ask her specifically when she started feeling fetal movement, because that would be.
And if she said it was this week, and that's why I came to the office, because 2 days ago I started feeling movement.
It would be more like, I would feel more comfortable with her current gestational age of about approximately 15 weeks.
Okay, it's 15, 16 weeks a common time when people note fetal movement?
No, I would actually believe she may be a little later than that.
Yeah, how much later?
I would believe closer to 20 weeks.
Okay, the examiners are they're just trying to get more information, and you're fine. I do meet people who claim to have fetal movement at 15 to 16 weeks. I will believe them. If we've got really good dating at 17, 18, 20 weeks, I think anywhere in a 15 to 20 week window, that's possible, but that's still a wider window, although it's not 13 weeks. Is there anything else that you could ask her that the examiners want to know sort of what things you go through to try to establish as reliably as possible gestational age? Anything else that, so we have previous medical encounter where she usually had an ultrasound or told somebody a menstrual period, or maybe somebody put a Doppler on her and got fetal heart rate with Doppler or something like that.
That was what I was going to say next with the Doppler.
Yeah. If she had no medical encounters, is there anything else we could ask her?
I'm sorry, say that again.
If she'd had no previous medical encounters that we knew of, this was the first time she showed up, Jen had previous evaluations anywhere for which that information available. Is there any other criteria that we could use that we might ask her about? So everything you said so far is great. You were thinking about, does she know the date of conception? Was this by chance such a reproductive technologies pregnancy, which she definitely had a very well established TGA at that point. But otherwise, is there anything else we could use?
Could do an abdominal examination, see if you could palpate the fundus.
True, and if we did that and it felt like 15 weeks, this is why we sort of thought that. As we said, we thought that she showed up around 14 to 15 weeks or so. Is there any other question we could ask her, though, that might get to something more than that?
No, we're
going through a brief checklist that actually goes way back to the ACOG Practice Bulletin 109, I believe it was, which is way back about 15 years ago or so. And it was actually the original Practice Bulletin on induction of labor. Any information she might have that probably nobody else would have, other than the date of her menstrual period, which she doesn't know, or the date of conception, which apparently she doesn't know.
Any other signs or symptoms of like first trimester symptoms, like nausea, vomiting, best tenderness?
Right. When did she notice symptoms of pregnancy? If she told you a specific window of weeks, a week in which she noticed that, how would that help you? As far as the time of pregnancy where women might start to notice those symptoms, is there a window that you're thinking of there?
I am believing that window could really be, well, I know that the symptoms usually peak around 10 weeks. So I believe symptoms would probably, start anywhere between 6 to 8 weeks of pregnancy.
Good. So now instead of a 5-week window, you're now down to a 2-week window. Good. That's good. Now that's not in the practice bulletin, but that's absolutely useful information. Very good. Anything else? If she could tell you the date at which she got a positive home pregnancy test, would that help you in any way?
Yes, that would be very helpful.
That's one of the ones. How does that help you as far as pinning down where she might be in the pregnancy?
That would help us determine, because you can determine those pregnancy tests, pretty early, usually around the time of what a missed period would be.
Sure. Although some people don't actually check at the time of missed period. Suppose she didn't test until maybe 4 or 5 weeks after she missed her period. Maybe she tested at the second missed period. So that the reason I bring this up is that you're doing everything exactly right. But when this line of questioning comes up, the important thing is that we need at least 2 data points or 2 criteria. One in this case is that you've got a 15-week exam. So And if she can tell you the data when she had a pregnancy test positive, and you go back and see how many weeks ago that was, those 2 data points actually help to define the pregnancy. A pregnancy test by itself might not help you. If the patient came in and seemed to be 28 weeks pregnant and told you she did a positive pregnancy test 10 weeks ago, that doesn't really help you much. But if you've got a 15-week gestation and she told you that 10 weeks ago she got a positive pregnancy test, that kind of confirms your 10-week gestation, right? Because a positive pregnancy test wouldn't be until about 4 to 5 weeks after the menstrual period. Does that make sense?
That does.
So all these cases, what the examiners are looking for is that we got to get at least 2 data points. So we've got menstrual period, date of conception, was it by ART? When did she notice pregnancy symptoms? That's a 2-week window. What do we find on our exam? Has she had a first trimester ultrasound? In this case, not. When did she first notice fetal movement? Doptone, so it's ultrasound, doptones, fetal movement, and then first, second, and trimester ultrasound. So last question then, since you've done very well on this. If at 15 to 16 weeks you're doing an ultrasound, what would you consider to be your standard error of measurement for dating a pregnancy at that time of the pregnancy?
It would be approximately 14 days.
Sounds good. Perfect. That'll give you everything. That's all the examiners want to know. But again, this is a really common question, especially because the ARRIVE trial has come up and that's so commonly discussed in the exam, and elective induction is now actually a really thing to discuss. Then when they start at the beginning, just remember, no matter what, the basic principle is I need at least 2 data points to really start to define the gestational age, and 3 would actually probably define it fairly well. But we have to have at least 2 so we have a comparison there. So you started off by saying menstrual period and first trimester ultrasound. Those are our 2 best. And then what they're going to go fishing for is, if you don't have those, give me 2 or 3 more that you could use to get at least 2 data points. And we just want to be able to throw out a few, which you did very nicely. Lauren, anything you'd like to ask about this before we move on? That was, again, really good discussion.
I don't believe so.
Okay, I'll come around for the questions at the end. I'll just check in and see if you have any. Thank you for doing that with us. That was a really good one once again. Let's move on, and we need one more of our candidates who is supposed to be on the hot seat this evening. I'm just going to go checking here for just a moment. Dr. Chen, I believe is supposed to be up. You, Dr. Yu Chen, if you would like to unmute yourself, I'll give you a minute, and I'll go back and check with Dr. Preb. There you go. Hi, Dr. Chen. I happen to have your case list sitting right here, ready to go. Can you hear us okay?
Yep.
Good. All right, ready to go. OBGYN or office preference?
Whatever you want to pick.
Okay, let's see. We've done only one office case. Can we do one more office case this evening? Is that okay?
Sure.
Okay, thanks. All right, so let's see. And anything on office that you would like to talk about then? Just I'll pick something at random, but if there's a topic you'd like to discuss, you do get to choose.
Whatever you want to do.
Okay, thanks. All righty. Let's see. Could we do case number 6? We could probably easily do this in the time allotted. 90-year-old with a labial ulcer. This is just kind of examiners are drawn to this, I think, like the moth to the flame. So a 90-year-old comes in, brought probably by a caretaker or a family member, because she's actually been irritated and she has a labial ulcer of indeterminate duration. What is your initial differential diagnosis, would you say, as far as when you walk in the room to see her, what are we starting to think of that we'll have to start checking out?
Yeah, so for a 90-year-old with a labial ulcer, I usually think of, well, cancer will probably be the top of my list.
We're thinking about this. I'm going to ask the same question we asked just a little bit earlier. What type of cancer would this most likely be?
Squamous cell.
Squamous, good. Carry on, thanks.
Okay, and then cancer, and then VIN.
Good.
And then for her, also like a pressure ulcer or trauma.
Good.
And then other like dermatosis, like lichen sclerosis, lichen simplex chronicus, lichen planus, like psoriasis, or maybe like an autoimmune disease like Behçet's.
Wow. Oh, very good. Wow, good.
And then
all right, we've got a good differential diagnosis. If you want to throw another one on, go ahead, but we can move ahead anytime you want.
That's pretty much it.
Okay, good. So you mentioned it was cancer, lichenoid disorders, and then we got things like pressure, trauma, ulcers, then we got into sort of benign dermatoses like psoriasis, eczema, things like that. You mentioned a number of lichenoid disorders. How, in your in your exam, how do you discriminate between lichen planus, lichen sclerosus, or lichen simplex chronicus?
For lichen sclerosis, a patient will usually have itching, and then there's a thinning of the architecture.
Good.
Sometimes you can see a little bit of a pale light pink lesions.
Sure.
And then with lichen simplex chronicus, usually the skin is on the thicker side, like a leathery looking lesion. But also patient can have itching as well. And then with the planus, usually sometimes you can see ulcerations, and also thinning of the skin. Yeah.
If you felt that this was most likely a lichenoid skin disorder of some sort, is it necessary to know the type in order to prescribe the correct topical treatment? The examiner's about to ask you need to biopsy this in order to prescribe treatment, or is that not necessarily the case?
You don't necessarily need to biopsy the lesion unless you have high suspicion for cancer. You can start them on a high potent corticosteroids to see if that will improve the symptoms.
What kind of steroid would you use in your practice?
I usually use cortisol, 0.05%.
Okay.
Yeah.
Good. So you'll tell them to apply the topical steroid. Do you give them any other instructions or make any other arrangements with them if you were thinking that this was your diagnosis?
I will have them apply probably daily in the beginning.
Yeah.
And then if it's for at least 2 to 3 weeks, and then if it's getting better, then she can maybe apply every other day, and then down to maybe once or twice a week. But I will have to see her prior to that, just to check on her to see how she's doing.
Okay. Why is it important for you to see her and follow up? Because it sounds like it is.
Well, if it's not getting better, then I would need to biopsy the ulcer to make sure it's not something else.
Good. Okay. Let's see. In your differential diagnosis, how would you discriminate the difference between lichen sclerosus atrophica and VIN, if those were two things that you were considering? Is there a way that you can identify one versus the other?
Yeah, I will have to do a colposcopy with possible biopsy.
Good. Okay. On your colposcopy, does a lichen sclerosus lesion look different from a VIN lesion?
You mean after I apply like
Can you tell? Yeah, if you apply your acetic acid, let it soak in for a few minutes, do your colposcopy. Can we discriminate between lichen sclerosus and VIN on the basis of a colposcopic exam?
I don't think so. You'll have to do a biopsy.
Okay. Well, tell me what you were thinking of colposcopy. What was your thought behind doing the colposcopy then?
Just to make sure there's no like a skip lesion that's not around where the main ulcer is.
Good. Good.
And then yeah, that would probably be the main reason I would do a colposcopy.
No, you're doing great. Again, like all of our candidates, and you are the sixth now, the questions are right down the line. You're making perfect sense to the examiners, right? It is very difficult to tell the difference between the LSNA and VIN. In fact, one of the things about that bringing the lichen sclerosus people back is that VIN can hide underneath there, it can coexist, and there's an increased risk of it. So sometimes you need to treat them, and then you can unmask it. Colposcopy is different for doing it, but you're right. Your colposcopy is to look for any other lesions on the vulva that were not visible to your actual examination, which might be pre-neoplastic like VIN. And a colposcopic exam would allow you to identify that because VIN is multifocal. Lichen sclerosus tends to be more contiguous, doesn't it? So you're right on both counts. It's difficult to tell, although sometimes you can. You would identify features suspicious for malignancy pretty quickly on a colposcopic exam. But the other reason is you're screening for anything that you haven't picked up on a visual exam that you might want to biopsy for other reasons. So you're absolutely right. And then you're right. You would bring them back, and if they had not improved, you would do a biopsy. If you do biopsy this in your office.
I'm sorry?
Do you usually do the biopsies in your office if you biopsy a vulvar lesion? For this 90-year-old woman, would you feel comfortable biopsying her in the office?
I did the biopsy in the office. I mean, it's a punch biopsy. It's a very small lesion, so usually it's well tolerated.
Excellent. No, the examiners they're interested in just how you respond to that. Some case you might say in this case I did because I was fairly assured that it was a benign lesion. A candidate might say, well, if there were any concerns for malignancy, I would send her to GYN oncology, or I would do it in the OR. You can answer that any way you want to. Good. So it looks like this is actually a vulvar lesion and says vaginal hormone therapy. Are we talking about estrogen therapy here?
Correct.
Got it. Okay. Of the things that you've listed on your differential diagnosis list, what types of things on that list would actually respond to topical estrogen therapy rather than to a corticosteroid?
Probably like a atrophic vaginitis picture.
Mm-hmm. Good. Can we? I know we can use vaginal hormone therapy for atrophic vaginitis. Is it effective for atrophic vulvitis as well?
Her lesion's actually very close to it's on the labial minora, so
great.
There is some maybe not vaginal tissue, but maybe like columnar tissue.
Mm-hmm. So you're thinking introital area? Is that what we're talking about?
Yeah.
Good. That's the word. That's the word I think you want to use in the
introitus. Yes.
Exactly, because there you can. Yeah. If we're looking at a true vulvar squamous skin of the vulva lesion, then this is not atrophy. This is actually an infectious process, or it's a lichenoid process or some sort of dermopathy, or it's a premalignant or malignant lesion. So or infections could be HSV or something else like that. But you're right. But if it's in the introital area, absolutely good. So in the exam, just be sure to specify that. The examiners might be interested in that just because of the way this case is worded, because it sounds like you got squamous epithelium and then you gave her vaginal hormone therapy, but you're making perfect sense because of where this was. And you thought it was more like menopausal genital atrophy that was related to the internal tissue. Does that sound right?
Yes.
Perfect. Good work. Great. Let's see. Very briefly, the last question. If you identified on your colposcopy, you identified something that did look like VIN, and you biopsied it, and it was VIN3, how would you manage that in a 90-year-old?
For her, most likely, you can do a wide local excision of the lesion, but I most likely will send her to GYN oncology to
there you go.
Manage
I agree. 90-year-old with this, I agree. I think that would be a great idea. Good. Now remember, in someone who is younger, you may absolutely be very comfortable doing a wide local excision. Remember, if on your case list you have these, or if you're going to opt for saying I would do that, be sure to go back and look at what is the current criteria for wide local excision of the vulva. You have to know depth of excision, you have to know margins and things like that. It is much easier to say I'd refer to GYN oncology. And this woman, I think that is exactly what most all of us would do. The examiners could still ask us, well, tell me sort of how does the GYN oncologist plan to mark out the wide local excision? In that case, it's fine to say I would have to look that up because your GYN oncologist is doing it. But if you have it on your case list that you did one, you have to know that. Good. Dr. Chen, thank you very much for doing that. That was 6 out of 6, and you did a really nice job with that. We walked through a number of different things on the differential diagnosis list, and it sounds like you have a really good system for identifying and diagnosing and managing appropriately. Anything you'd like to ask about as far as questions before we finish up here?
No, I don't think so. Thank you.
Good.
Muted.
Thank you very much for doing it with us. We do have a couple questions here. Dr. Zoma and Dr. Elman, I think we're waiting. Get to Dr. Zoma first. Melody, if you have a question, there you go. But, yeah,
Hi, so I have a quick question about the interstitial or corneal ectopic. Is
Oh, yes.
I'm trying to think like hypothetically what the examiners could ask. And I had a case in residency where the patient did not want surgery. She was
Right.
above the criteria or like just, you know, lower risk of success, but she really didn't want surgery. So she opted for the multi-dose regimen.
Yes.
But we actually kept her in-house just for observation of abdominal like serial exams as well as like bleeding precautions because she lived far. So
Yeah.
is that frowned upon in the sense of like wasting of resources of keeping a patient in house for management, or could I just say based off of the risks of failed methods and really, you know, wanting to conserve her uterus, like we opted to keep her for close evaluation?
That's it. That would be unusual, but if your hospital permits that, and did you consult with anybody else before you decided to admit her and do this? Was this a team approach, or is this just your decision to do it?
This was a team approach
There you
with
go.
multiple faculty members, as
Good.
well
There you
as we actually got almost approval from the GYN chief to see if this would be appropriate management in regards to close observation.
Good. So I think a nice answering the exam would be, this was very unusual management, and I'm not sure that I've heard of other people doing it. However, this was a team approach. I consulted with a number of senior colleagues, including our department chairman, and it was agreed that given the patient's strong desire to avoid surgery and given our understanding that there are significant risks and that a rupture could occur with catastrophic consequences over short order, it was decided to manage her as inpatient. What you're describing to the examiners is that you did actually take some time to develop a consensus because this is unusual. And there's a specific reason for doing it. She really wanted to avoid surgery, and you are aware of the potential risks of managing these things medically. And that just like for any ectopic pregnancy, they can rupture without warning, but the consequences are more serious here than if it would be a fallopian ectopic pregnancy in general.
Okay.
You would cover your bases very nicely with that one, Melody. Very nicely. That was a good one to work out. I've actually not heard of that before. Thanks. Let's get to Dr. Elwin from Medina. Go ahead. Hi.
Hi, I just had a question in terms of monitoring the response for, like, if you do multi-dose methotrexate where it's the fixed dose, how do you, like, when do you check their betas? And I've never given it. I've only.
Well, if we do a multiple, the protocol should be the same. We want to do day 4 and day 7. If you're going to do a second dose, you're really just starting the round again to see if she will. And you can do, and your fixed dose can be either a single dose regimen or you can do the 3-dose regimen, which is a little bit different.
Because yeah, they have
this regimen. I'd actually have to look up the protocol for when you do the levels with the 3-dose regimen because I think it's different. I have to check that out. But if you're doing fixed dose, the protocol is pretty much the same. If you're doing multi-dose regimen, you still follow the protocol for a number of days to check your titers.
Right. Sorry, but because they have the one listed in here that says like I think on day 1, 3, 5, and 7.
Oh, 1, 3, 5, and 7 for multi-dose regimens.
Let me look at the.
There is one. There's a 1 and 3, a 1, 3, 5, and there's a 1, 3, 5, 7, which I've never known anybody to do, but that does exist, and that's unusual enough that I'd have to look up what the protocol is for checking the levels, because then you end up checking levels, I think, in between doses.
Okay.
And I do not know what that is because I've never done it. But if that's something that you think you might have to discuss on the exam, look that up because there's a protocol somewhere. I'll go look for it.
But if that just came out of a structured case, that's not something we would need to know.
No, they're not going to ask you that in a structured case. But they could. Remember these Part D questions, they can put at the very end, they can put a question in there that they are pretty sure we don't know the answer to. And the answer with that is, I'm not sure, I would have to look it up, but your patient's still perfectly safe because before you consider giving her a 4-dose multi-dose regimen, you're going to go and find out exactly what the protocol is so you do it properly. So that's fine. This is not a situation where you have to do it immediately to save the patient's life. That's planning. Right. So in that case, you're perfectly allowed to say, I would go look at it.
Okay.
What you would do before you started it.
Right. Okay.
Good work. Yeah, thank you. Thank you to all of our candidates. So 6 out of 6. Again, just to reinforce what we've done this evening. Excellent discussions all along. We are just pressing the examiners who ask questions and challenge a little bit more, but they're just trying to draw us out and get us to specify and think about a little bit more about what we're doing, and just to see if we have a structure in our responses. And all of our candidates actually have. This has been 6 really, really nice discussions all evening long. Thank you again to all of our candidates who participated this evening. Remember, these are archived. You can come back and listen to our discussions anytime on the ExamPro website if you want to check out or just review anything that we talked about this evening. We are continuing on this week. Tomorrow, Monday, will be structured case review. Thanks, everybody. Have a great rest of the evening.